Today, we're exploring drugs that promote fluid excretion, commonly known as diuretics. These medications play a vital role in managing conditions like hypertension, heart failure, and edema. Don't miss the companion video featuring a 10-question MCQ quiz. Find the link in the description below. Now, let's dive into the learning objectives for this session. By the end of this lecture, you'll be able to classify diuretics based on their site of action and chemical structure. You'll understand the mechanisms of action of major diuretic classes and how they influence renal physiology. Learners will be able to identify common clinical indications for each diuretic class and their therapeutic applications. You'll gain insights into the pharmacokinetics of these medications, including absorption, metabolism, and elimination pathways. You'll learn about the side effects and safety considerations associated with diuretic use, ensuring patient-centered care. Finally, you'll explore the role of newer diuretic agents in clinical practice and their potential benefits. Now, let's start by defining what are diuretics. Diuretics are a class of drugs that promote increased urine formation by inhibiting renal tubular reabsorption of sodium. Clinically, these drugs are essential for managing hypertension, edema, heart failure, and specific renal disorders. The classification of diuretics is based on their site and mechanism of action within the nephron. This classification aids clinicians in selecting appropriate diuretics tailored to individual patient needs and conditions. Diuretics are classified into 5 major subclasses: carbonic anhydrase inhibitors, loop diuretics, thiazide diuretics, potassium-sparing diuretics, and osmotic diuretics. Each subclass is defined by its specific target within the nephron, influencing distinct physiological effects. These subclasses vary in potency, duration of action, and therapeutic applications. The table presented here summarizes the subclasses of diuretics along with representative examples for each. Acetazolamide represents carbonic anhydrase inhibitors, which act on the proximal tubule. Furosemide and bumetanide are examples of loop diuretics, targeting the loop of Henle. Hydrochlorothiazide and chlorthalidone exemplify thiazide diuretics, which act on the distal convoluted tubule. Spironolactone and amiloride are potassium-sparing diuretics, working in the collecting duct. Finally, osmotic diuretics like mannitol act across the nephron by increasing osmotic pressure within the filtrate. Let's now look at the mechanisms of action and indications of diuretics. Diuretics primarily act on different segments of the nephron and the kidney to increase sodium and water excretion, thereby reducing fluid volume. We will start by looking at loop diuretics. Loop diuretics act on the thick ascending limb of the loop of Henle, where they inhibit the sodium-potassium chloride cotransporter, leading to significant sodium, chloride, and water excretion. By reducing intravascular volume, they are highly effective in managing conditions associated with fluid overload, such as heart failure and pulmonary edema. Drugs like furosemide are used in acute settings to relieve symptoms of severe fluid retention. They are also indicated in chronic kidney disease to manage edema. Their rapid onset makes them ideal for emergency relief of conditions like acute left ventricular failure. Thiazide diuretics target the distal convoluted tubule, where they inhibit the sodium chloride importer, reducing sodium reabsorption and promoting diuresis. This mechanism decreases blood volume and systemic vascular resistance, making them a first-line treatment for hypertension. Additionally, drugs such as hydrochlorothiazide are indicated in mild to moderate edema. These drugs are particularly useful in managing calcium nephrolithiasis by reducing urinary calcium excretion. Potassium-sparing diuretics act at the collecting ducts and counteract potassium loss by inhibiting aldosterone action or blocking sodium channels. For example, spironolactone, an aldosterone antagonist, reduces sodium reabsorption and prevents potassium excretion, making it invaluable in heart failure with reduced ejection fraction and primary hyperaldosteronism. This subclass is also used in conditions like cirrhosis-related ascites to maintain potassium balance and minimize hypokalemia. Carbonic anhydrase inhibitors, such as acetazolamide, work in the proximal tubule by inhibiting the enzyme carbonic anhydrase, reducing bicarbonate reabsorption and causing mild diuresis. This action helps reduce intraocular pressure, making these drugs particularly effective in treating glaucoma. Additionally, they are used in managing acute mountain sickness by correcting metabolic alkalosis. Osmotic diuretics, like mannitol, act throughout the nephron by increasing the osmotic pressure of the glomerular filtrate, thereby preventing water reabsorption. This mechanism is particularly useful in reducing intracranial pressure and intraocular pressure in emergency settings. Mannitol is also employed to promote diuresis in cases of acute kidney injury where renal perfusion needs to be maintained. Each subclass of diuretics offers unique mechanisms and clinical applications, making them versatile tools in managing various fluid and electrolyte disorders. Pharmacokinetics. Let's review the absorption, distribution, metabolism, and excretion of diuretics, focusing on their pharmacokinetic profiles across 5 major subclasses. Absorption. The absorption of diuretics varies depending on their subclass and physicochemical properties. The following table presents a detailed summary of the absorption profiles of major diuretic subclasses, highlighting key differences in their bioavailability and the impact of the first-pass effect. This structured breakdown facilitates a clearer understanding of how each subclass is absorbed, ultimately impacting their onset of action and therapeutic efficacy. For instance, loop diuretics like furosemide exhibit variable bioavailability, 50 to 70%, due to erratic gastrointestinal absorption. Thiazide diuretics, such as hydrochlorothiazide, are well absorbed orally with bioavailability near 70%. Potassium-sparing diuretics, including spironolactone, undergo significant first-pass metabolism, leading to a reduced systemic availability of approximately 40%. Carbonic anhydrase inhibitors and osmotic diuretics show minimal first-pass effects, maintaining high bioavailability. Osmotic diuretics such as mannitol are administered intravenously, particularly in the treatment of intracranial pressure. Distribution. The distribution of diuretics depends on their lipid solubility, plasma protein binding, and volume of distribution, VD. The table provided summarizes the distribution profile of major diuretic subclasses, detailing their tissue permeability and binding characteristics. Loop diuretics, such as furosemide, are extensively bound to plasma proteins, greater than 95%, restricting distribution to the extracellular compartment. Thiazides, like hydrochlorothiazide, show moderate tissue distribution with a volume of distribution of approximately 0.8 liters per kg. Potassium-sparing agents like spironolactone exhibit high lipid solubility, facilitating tissue penetration. Carbonic anhydrase inhibitors have a small volume of distribution, of approximately 0.2 liters per kg, reflecting limited tissue binding. Osmotic diuretics like mannitol are confined to the vascular compartment. Metabolism. Metabolism of diuretics varies across subclasses, influencing their active metabolites and clinical duration. The table provided summarizes the metabolic profile of major diuretic subclasses, detailing their enzymatic pathways and resulting metabolites. Loop diuretics like furosemide undergo partial hepatic metabolism via CYP450 enzymes, while thiazides like hydrochlorothiazide are minimally metabolized. Potassium-sparing agents like spironolactone undergo significant hepatic metabolism, forming active metabolites such as canrenone. Carbonic anhydrase inhibitors like acetazolamide undergo limited metabolism, with most of the drug excreted unchanged. Osmotic diuretics like mannitol are not metabolized. Excretion of diuretics. Excretion of diuretics is primarily renal, with subclass-specific variations in pathways and half-lives. The table provided summarizes the excretion profiles of major diuretic subclasses, detailing their routes and elimination characteristics. Loop diuretics like furosemide are excreted largely unchanged via the kidneys, with a half-life of 1 to 2 hours. Thiazides like hydrochlorothiazide have a renal clearance with a longer half-life of 8 to 12 hours. Potassium-sparing diuretics like spironolactone undergo biliary and renal excretion. Carbonic anhydrase inhibitors are cleared rapidly through renal pathways. Mannitol is exclusively eliminated via glomerular filtration. Side effect and safety profile of diuretics. The side effects and safety profile of diuretics are diverse across their 5 subclasses: thiazides, loop diuretics, potassium-sparing diuretics, carbonic anhydrase inhibitors, and osmotic diuretics. Let's start by looking at the common side effects associated with these subclasses. The table presented here highlights the common side effects associated with each subclass of diuretics, providing a comprehensive overview. Thiazides, such as hydrochlorothiazide, frequently cause hypokalemia, hypercalcemia, and hyperuricemia, with potential management including potassium supplementation or dietary adjustments. Loop diuretics like furosemide often lead to electrolyte imbalances, including hypokalemia and hypomagnesemia, alongside ototoxicity, which can be managed by dosage adjustments. Potassium-sparing diuretics, such as spironolactone, carry a risk of hyperkalemia, necessitating close monitoring of potassium levels. Carbonic anhydrase inhibitors, exemplified by acetazolamide, may cause metabolic acidosis and paresthesia, managed by discontinuing the drug if symptoms persist. Finally, osmotic diuretics like mannitol can lead to electrolyte imbalances and volume overload, requiring fluid balance monitoring. Serious adverse effects of diuretics. While common side effects are often mild, it's important to consider the serious adverse reactions associated with this class. The table presented here summarizes serious side effects of major subclasses, alongside risk factors and management strategies. For example, furosemide can cause acute kidney injury, particularly in hypovolemic patients, requiring renal function monitoring. Spironolactone has been linked to gynecomastia due to hormonal effects, necessitating a switch to eplerenone. Acetazolamide may rarely induce aplastic anemia, which warrants immediate drug discontinuation. Mannitol can exacerbate pulmonary edema in patients with heart failure, requiring careful patient selection. Warnings and contraindications. Careful consideration must be given to the warnings and contraindications for diuretics. Thiazides should be avoided in patients with severe gout due to hyperuricemia risk. Loop diuretics must be used cautiously in those with severe renal impairment to prevent further kidney damage. Potassium-sparing diuretics, such as spironolactone, are contraindicated in patients with hyperkalemia or significant renal dysfunction due to the risk of life-threatening potassium retention. Acetazolamide is contraindicated in patients with sulfonamide allergy. Mannitol should not be used in individuals with active intracranial bleeding due to exacerbation of cerebral edema. Safety in pregnancy. Assessing the safety of diuretics during pregnancy is critical for maternal and fetal health. Furosemide and spironolactone are contraindicated due to risks of fetal growth restriction and antiandrogenic effects, respectively. Conversely, hydrochlorothiazide may be cautiously used for managing hypertension, though only when benefits outweigh risks. Mannitol is also cautiously used in certain emergencies, such as intracranial hypertension, under close supervision to minimize fetal harm. All diuretics should be prescribed with careful risk-benefit analysis during pregnancy. Regarding lactation, evaluating the use of diuretics during breastfeeding is also important to avoid adverse effects in infants and maintain milk supply. Furosemide, due to its potent diuretic action, is contraindicated as it can reduce milk production. Similarly, spironolactone is avoided due to its hormonal effects. On the other hand, hydrochlorothiazide at low doses is considered compatible with breastfeeding for managing mild hypertension, and mannitol can be used cautiously in acute settings without significant lactation concerns, provided infant monitoring is ensured. Drug interactions. Understanding the interactions of diuretics is vital for safe clinical use. The table below summarizes common drug interactions associated with each subclass, highlighting key considerations for co-administration. For instance, furosemide with aminoglycosides increases ototoxicity risk, necessitating close auditory monitoring. Spironolactone with ACE inhibitors elevates hyperkalemia risk, requiring potassium level monitoring. Acetazolamide with phenytoin may lead to decreased seizure control due to altered drug metabolism. There is enhanced the risk of hypokalemia when thiazide diuretics, such as hydrochlorothiazide, are used with corticosteroids, potentially causing muscle cramps and arrhythmias. Regular potassium supplementation or monitoring may be required in such cases. Lastly, let's explore newer therapies that fall under the class of diuretics. Dapagliflozin, a sodium glucose cotransporter 2, SGLT2, inhibitor, demonstrates superior efficacy in reducing fluid overload compared to conventional loop diuretics. Its unique ability to promote glycosuria alongside diuresis offers additional benefits in patients with heart failure and diabetes, though cost and long-term data remain key considerations. Now that we've explored diuretics, let's take a moment to recap. We've covered the major classes of diuretics and their mechanisms of action. Key indications, such as hypertension, edema, and heart failure. Pharmacokinetics, including renal elimination and variability among agents. Common side effects like electrolyte imbalances and more serious adverse events such as acute kidney injury. Important contraindications and drug interactions to monitor in clinical practice. Lastly, newer agents such as dapagliflozin, with its dual diuretic and metabolic effects, have been discussed. In conclusion, understanding the pharmacology of diuretics is critical for optimizing fluid balance in clinical care. These medications play a vital role in managing cardiovascular, renal, and metabolic conditions effectively. Be sure to check out our next video on ACE inhibitors, where we'll explore their mechanisms, indications, and clinical relevance in managing cardiovascular and renal diseases. For more in-depth information, refer to Katzung and Trevor's Basic and Clinical Pharmacology, Rang and Dale's Pharmacology, and the latest edition of the British National Formulary, BNF. These trusted resources provide comprehensive insights into pharmacological principles and drug therapy. Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with others. Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.